and get started. Perfect. So thank you very much for joining us. We're starting into the fall. It's September. It's hard to believe we're moving so quickly through everything, but I'll share my screen and we'll kind of go through the September online JVS Journal Club. We have two great pieces of work that we're going to be looking at today. Ambar Mehta and V. Patel from Columbia, as well as Priya Patel, are here to go over their paper. Low volume surgeons can have better outcomes at certain hospital settings for open abdominal aortic repairs. And then Dr. Menard and Ido Weinberg are here to talk about and answer questions from their baseline modern medical management in the BEST-CLI trial. Our host institutions tonight are LSU and NYU. From NYU, we have Dr. Catherine Teeter, who is an assistant professor and also associate program director, and their second year vascular fellow, Dr. Matthew Pergamo. From LSU, we have Dr. Mal Sheehan and Dr. Daniela Medina, who is a second year vascular resident. The authors, as I mentioned, from both papers, Dr. Ambar Mehta, Dr. Priya Patel, and Dr. V. Patel, are going to be discussing or answering questions regarding the aortic paper, and then Dr. Menard and Dr. Weinberg from Harvard. We have two editorial board guests this evening, Dr. Matthew Eagleton, who is professor and chief of the Division of Vascular Surgery at Mass General Hospital, and Dr. Caitlin Hicks, who is associate professor of surgery at Johns Hopkins. Just a couple of housekeeping things. We'd like you to stay muted, but we will prompt you to put your questions and comments in the chat. The moderator may call on you to speak and go over these. The event is being recorded, as you heard for just a minute ago. And then the October JVS Online Journal Club is October 11th at 6 p.m. Central Time. Our host institutions will be Thomas Jefferson University. Dr. Babak Abai is here with us tonight, and then the University of Rochester will also be hosting. So I will stop sharing my screen, and from here, I think we will let our first group take it away.
Thank you, Misty. Make sure I'm going to share this now. Okay, so our article that we selected tries to correlate surgeon experience with outcomes in open aortic surgery. So I wanted to take the opportunity here to inject a few of my biases into the conversation before Daniela gives a proper review of the article. So our specialty is kind of obsessed with this, right? We are always worried that we're not going to have enough aortas for the residents to train on, and they will go into practice kind of incompetent to do these procedures. So who's going to do them? And we've been, multiple papers from different ones. My friend, Dr. Jason Lee, gets into the act here with this predicted shortfall in open aneurysm experience that he published several years ago. And if you ask the cardiologist, they probably don't even think we need to do open aortic surgery anymore, right? They are always publishing, is this of historical interest only? But despite all the hysteria, if you actually look at the numbers of graduates in integrated programs, now here we looked at 2019 and 20, 20 to 21, and 21 to 22, just in case there were any kind of bumps or differences. So when most people talk about the dearth of aortic experience, they're really talking about just open aneurysms, which I have circled there. And yes, most integrated residents finish it with about 15 to 20 open aneurysms over the course of their training. But what's important to do is look at other aortic experience they're getting. So if you look at the numbers of aortic occlusive disease, the mesenteric cases, aortic trauma, you'll see that their numbers are actually much, much better. And most integrated residents finish with between 40 to 50 open aortic cases, which is probably enough to give them competence. And this doesn't include other open abdominal vascular procedures like spine exposures, iliac inflow procedures, iliac trauma, caval procedures. And doing any of those things will probably give you experience towards doing open aortic work. And so with the fellows, it's basically the same. Surprisingly, their numbers are almost identical to what the integrated residents finished with. So we are graduating vascular trainees with between 40 to 45 open aortic cases at the finish of their training. But there's other things we could do if we think this isn't enough. You know, in Australia, they kind of send us modular training. They send you to places which have more experience in certain things, and then the trainees can kind of pick their pathway. And also how we train them. You know, we all kind of grew up in this Halstead, see one, do one, teach one thing. But probably now we're learning, you know, that's not always the best way. And if you're, you know, sitting up there watching Halstead do the procedure, you know, I'm not sure what you're getting out of it, and you probably don't want that guy operating on you. So we've learned that learning and experience is not a linear relationship, and we need to kind of do more of this model. So then smart help, then kind of dumb help. You know, you're just a passive assistant, and then no help. But you know what we've been trying to do is influence this with actually having the trainees help themselves, right? Having some simulation in between experience, so we can add to this model within the smart help. Then there's self-help, right? The trainees don't have to always learn in the operating room. They read at home. Why not? They're doing some of these procedures at home, or at least the steps you can replicate, and then get back to that smart help and progress along at a quicker pace than we're doing. So now that you've heard all my biases, we'll listen to Dr. Medina talk about what's going on in real world hospitals. And I will stop sharing.
All right, I'm gonna go ahead and share. Good evening, everyone. I'm Daniela Medina. I'm one of the LSU vascular surgery residents, and today I'm going to be presenting a retrospective study that used the BEST-CLI database and it's titled Low Volume Surgeons Can Have Better Outcomes at Certain Hospital Settings for Open Abdominal Aortic Repairs. This paper was just published on JVS on May of this year. So a little bit of a background that led the authors to conduct this study was basically the fact that low volume surgeons are known to have worse outcomes compared to high volume surgeons. And because of this, certain initiatives have been set in place for a low volume surgeon to, whenever they're presented with a patient who needs a complex high risk operation, for them to transfer them to a more expert or a high volume surgeon. However, this type of initiatives, they've presented many challenges because one, there's only so many experts, there's only so many high volume surgeons and centers across the nation. And two, not every patient has the ability or is able to just travel to where these centers or where these surgeons are. So what that means is that no matter what, low volume surgeons will be performing these high risk operations such as an open abdominal aortic reconstruction. For that reason, the authors of this paper went ahead and looked at the post-operative outcomes within 30 days of the operation for patients undergoing open abdominal aortic surgery by low volume surgeons. So again, the objective of the study was to identify differences in short-term post-operative outcomes among low volume surgeons for open abdominal aortic surgeries by different hospital settings. In order to do this, the authors went ahead and looked at the BEST-CLI from years 2012 to 2019. They extracted data from patients who underwent open abdominal aortic surgery for both aneurysmal disease and occlusive disease, and ended up with a total of 14,000 patients, more or less. Out of those 14,000 patients, they went ahead and excluded patients with ASA class 5, as well as those whose surgery was performed by a high volume surgeon. A high volume surgeon in this study was that one who had performed more than 7 open aortas within 1 year. So they ended up including a total of 10,252 patients to the study, and then divided those based on the hospital volume. A low volume hospital for this study was a hospital where they were performing less than 10 open aortas per year, and a high volume hospital was one where they were performing 10 or more open aortas, or they had a high volume surgeon in place. They then looked at 30-day outcomes such as mortalities, complications, and failure to rescue, and then did univariate and multivariate analysis. So in here, we have a table 1 that shows the demographics of our study population. The mean age for the patients were about 65 years old. The majority were Caucasian males, and both aneurysmal and occlusive disease distribution was pretty equal, are both among the study populations. Now, interestingly, patients who had their surgery completed at a high volume hospital were more likely to have aneurysmal disease, have a retroperitoneal approach, and have a more proximal clamp site as well. That's just something interesting to throw out there. Then they went ahead and looked at the distribution of patients operated on by low volume surgeons by hospital settings. And first thing is that you can see more than 70% of open abdominal aortic surgeries were performed by a low volume surgeon. After that, we can see that about 66% were performed at high volume hospitals, and about 30% were performed at a hospital where there is a high volume surgeon. Then when looking at the outcomes, so death, complication, and failure to rescue, and among like the different criteria, we can see that in the univariate analysis, there wasn't really any statistically significant differences between the study groups. However, when we look at the multivariate analysis for aneurysmal disease specifically, so again, when we're looking at the outcomes, so death, complication, and failure to rescue for patients undergoing open abdominal aortic surgery by a low volume surgeon, here, those patients who underwent the surgery or whose surgeries were completed at a high volume hospital not only had decreased mortality rates, but also had lower failure to rescue rates. Not only that, but those who were operated at a place where there was a high volume surgeon available, they also had lower mortality rates. Now, again, this was just for aneurysmal disease, because when they looked at aortic iliac occlusive disease, there wasn't really any statistically significant differences between the outcomes for the different study groups. So the conclusions of the study are simple. First thing, low volume surgeons are doing the majority of open abdominal aortic surgeries across the nation. Then those patients who are getting those patients who are getting operated by a low volume surgeon or getting an open abdominal aortic aneurysm repair, specifically again for aneurysm disease, not only do they have lower mortality, but they also have lower failure to rescue at a place where there's high volume hospitals. And that kind of makes sense because these places tend to be like an aortic center or have like a multidisciplinary approach to post-op care for these high-risk patients. And lastly, outcomes of low-volume surgeons did not differ by hospital volume for aortic iliac occlusive disease. This study does have limitations. So first is the retrospective nature of it. Second is the lack of hospital information. We don't really know the size of these hospitals, the number of beds, the ranking. Is it a trauma center? Is it not a trauma center? Do they have residents? We don't really get that information from this study. And lastly, the study doesn't really assess a surgeon's experience. So they sort of just say a surgeon who's doing less than 7 open aortas is a low volume surgeon, but do we know if that surgeon in the past was doing 15 open aortas a year? We can't really assess that based on this study. And that's all I have. Thank you so much.
Great, thanks, Daniela. Let me start off by asking you some questions until we get some from the audience. I think you presented that the paper shows that patients who are treated by a low volume surgeon, but at least in a high volume center, do better than those in a low volume center. Yet there's a lot of low volume surgeons doing these procedures, especially for aortas and potentially for more complicated aortas that require a supraceliac clamp or a suprarenal clamp. Are you then making an argument, and this comes up all the time, for regionalization of aneurysm care? I know in the beginning you commented perhaps that that's difficult for patients to get to those types of centers, but if the outcomes are better, the mortality rates are lower, should we move in that direction? I'll let you chew on that one a little bit.
No, I think that's an excellent, oh, sorry. I think that's an excellent question because that's something that I was thinking myself. But at the same time, the authors made a great point in their introduction when they were saying how not every patient, like if you tell a patient like, hey, you gotta travel to Houston, that's close to New Orleans, or you gotta travel X, Y, and Z so many places far away. I don't know if every patient can do that. So at that point, what do you do? Do you just sit on a 9 centimeter aneurysm, or do you do your best and watch the patient like a hawk, like you should be doing for every patient? So
Daniela,
Oh.
sorry to interrupt. Hi, everyone. My name is Umber. Thank you so much for the opportunity. I'm happy to chime in as well. Dr. Eagleton, to answer your question, I think for very complex surgeries, just like with any complex surgery in other fields, there needs to be a level of regionalization. As we know, there's a massive association between volume and outcomes with these complex procedures that all of you know. However, it's really important, I think, for us to realize, and this was the reason why we decided to do the study, that it's going to be impossible to regionalize every patient for the number of reasons that Daniela mentioned. There's not just going to be patient logistical factors, but in terms of the time, cost, and money, it's going to be very difficult for many patients to get the care. And oftentimes, it's also very difficult to really understand if we put a regionalization initiative in check, how do we truly know when folks are following it and the likes? The idea then was to take a look at the patients who are getting their surgeries by low volume surgeons and understand, is there a trend where they may have better outcomes? And so to answer your question, and I think in 2 points, one is, yes, there should be regionalization with the recognition that it's going to be impossible to fully regionalize all patients. And the second is that for a reasonable proportion of patients who will likely still be getting an open AAA repair by someone considered a low volume surgeon, if we can then try to encourage them to do those types of procedures in larger hospitals, that could be a way to better continue to improve these outcomes. I think for why they have better outcomes, these surgeons in high volume centers, there's a lot of hypotheses there, and happy to jump into them as well. But I'll pause there to see if there are any other questions as well.
I think Dr. DeMuzio raises a great question in the chat, is how do the studies like these account for procedures done by 2 attendings, especially at a center where there's low volume surgeon and a high volume surgeon? Is it possible that the low volume surgeon is being mentored or proctored or guided by the high volume surgeon?
That's a great question. That is a very strong limitation of the study. I'm happy to also go through some of the other limitations. So one, I think depending, this data was extracted from VQI, so it depends in terms of who the specific surgeon was listed as primary for that aortic repair. In terms of the other limitations of this study, as Danielle mentioned, we couldn't account for the number of years an attending may have been operating for. For example, someone who's been operating for 20 years only does 3 open, may have better outcomes than someone who just came out of fellowship and does 10 a year. In addition, we cannot do dual attendings as mentioned. In addition, we also use the leapfrog criteria as the initial first step to figure out who was a low volume surgeon. However, there's a lot of research out there that shows that the leapfrog criteria may not be the most accurate. However, given that there is some prior literature that shows there is a relationship with using the leapfrog criteria to figure out low and high volume surgeons, we figured it would be better to use that rather than make our own arbitrary value or threshold.
So when you, and I think you covered this in the methods, but let me reiterate, say someone like me, I operate in 5 hospitals. Will you have captured all the aortas I did, or will you only have captured them in the hospital which you're referencing? Or I guess there's a possibility if I operate in 5 hospitals, not all of them have VQI as well.
It would be capturing all of your hospitals where they are participating in VQI. So if only 3 out of the 5 are participating, that would also be another limitation that I admit we did not think about.
No, I mean, there's no way to overcome that with this. You'd have to, use some kind of billing data or CMS to get over that hurdle, I would guess. But so if I do things in multiple hospitals, you're still capturing every aorta I'm doing.
Correct, as long as each hospital is participating in VQI.
I got you. And then you code it. Okay. Yeah, it's interesting because it can get a little redundant with, multiple surgeons but I don't know what percent of vascular surgeons operate in more than one institution, but I think the number is actually quite high, especially for private practice groups. So it'd
That's
be
a really,
interesting from that. Yeah.
it's a really
Yeah,
great point. It's something that also could be easily determined in BQI.
Yeah, yeah. And it might be interesting following this up with CMS data, because I think CMS would capture the assistant surgeon as well, the 80 code, if that's how the mentor or the proctor, as Dr. Eilton referred to them, would likely bill for assisting in a case like that. And so we could kind of see if there's an effect from having a more experienced proctor doing the cases as well.
I got
Where are you gonna go ahead, Matt?
I don't see any other questions there, but I have two questions for you. Maybe I can ask. Why do you think there's a difference between occlusive disease and aneurysmal disease? Just the technical operation?
That's a great question. I think from my understanding so far, it could be that occlusive disease with aneurysmal disease, it may be a little bit harder to get the exposure because depending on the size, in addition, it may require a higher proximal clamp site, which then makes the procedure overall a little bit more complex and has a higher risk, especially with more proximal clamp site and the higher ischemia time with having worse perioperative outcomes, which means that the volume effect will be even greater as seen.
And my second question, and you may not be able to answer this, what is the difference? Why is there a difference in outcomes between the low volume surgeons at a low volume hospital versus a high volume hospital? Is it a technical problem they're having in the operating room because of their experience? Is this a systems issue? And I suspect it's a systems issue, but what specifically can we highlight? What complications occurred more readily at one spot versus another? I don't know if you'd be able to answer that from BQI data, but that'd be a big question I would have. And can we then turn low volume surgeons at low volume centers and improve their performance?
That's a great question. I think what we also found, while low volume surgeons had better mortality rates at high volume centers, the reason why was also because they had lower failure to rescue rates at these high volume centers. So what that means is that at these high volume centers, they were able to better identify complications earlier and address them appropriately as well. And I think as you all know better than I do, that all comes down to the massive ancillary support help that comes with taking care of a patient postoperatively. Do the ICUs have guidelines and frameworks in terms of how to manage these patients? How familiar are the intensivists in terms of understanding when a patient is deteriorating and it's a surgical issue? In addition, I think it follows all the way through in the sense of the nurses being a lot more experienced and the likes. So my hypothesis is that there may always be a technical aspect, but the majority would be the systems and the postoperative care.
So we had a question coming in about, do we think occlusive disease can be a gateway for low volume surgeons to become high volume surgeons? I guess inferring that you can do more open aortas, which is always a good thing to think of when you're, stenting the hell out of some of these occlusive disease cases. But what do you think?
I think on the surface, that sounds like a great idea. I think practically that would be very infeasible because what that would require was somebody getting a referral for someone who has bad aortoiliac disease and then giving that patient to another surgeon. I think for the most part, that may happen. For that to happen enough for a number of reasons to help a low volume surgeon become a higher volume surgeon, I would be more pessimistic.
Yeah, I think one of the
I can comment on that. So I think the question is, does doing an aortobifemoral bypass graft translate to better outcomes with open AAA repair? Is that fair to say, Mel?
Yeah, I think that's where they're getting at.
Yeah, so I mean, the SBS guidelines are 10 aortas, whether they're aortoiliac or AAA, right? It doesn't say 10 specific aneurysms or 10 aneurysms in Marfan's patients. It just says that 10 per year is what they designate as a center that should be doing them. But I think aortoiliac occlusive disease, I think it allows familiarity with the aorta, the anatomy, the retroperitoneum. So I think that may translate to some degree to better outcomes. But I think, again, an aortoiliac disease patient's neck is very different than a patient who's got a friable neck that's not aneurysmal, but eventually will become aneurysmal, right? And so I think there is some translation, but I don't know if it's a one-to-one. I think maybe doing more aortoiliacs, maybe doing suprarenal clamps, working faster to remove those suprarenal clamps may translate to similar sort of volume-based improvements in system or surgeon or hospital outcomes, but I'm not sure that it'll translate one-to-one because aneurysms are a little bit more complex in terms of where the clamp has to be, how you manage the visceral vessels, whereas occlusive disease, generally, you have a normal, sometimes calcified, normal caliber aorta in the infrarenal location.
Yeah, I don't think there's any doubt that they're more complicated, and I think your data shows that, right, with the outcomes. And so I'm always surprised, like the data I showed. I thought that the open aneurysm experience in trainees would be, much less by now, and that the, occlusive disease would be much more, but they're actually fairly equivalent. And kind of have sustained even throughout the modern EVAR era, which is kind of surprising to me. These are means, they're not, obviously there's going to be outliers, but it is surprising that it persists to the level that it does in training. But yeah, I think you're right. I mean, anybody does a lot of these knows that the aneurysms are much more complicated. But I do think there's some translation and skill there.
Yeah, I would agree.
I think it's nice to know, if you all look back 20 years ago, Gib Upchurch and Justin Dimmick wrote a similar paper based on an NIH database with pretty much similar results, that for aortic aneurysm disease, and the surgeon wasn't quite as important as the center. High volume surgeons and high volume centers did extraordinarily well, but lower volume surgeons and high volume centers did well as well compared to low volume surgeons at low volume centers. So they looked at a little bit different than this, but it's nice to know we've been consistent over the past couple of decades.
I think one other point that maybe Ambar talked about it, but he didn't. And again, my apologies for being late. I had a case, but he's done a lot of nice work on failure to rescue, which is basically a patient gets a complication and how likely is that complication to predict death or 30-day mortality. And higher volume centers have a higher or a lower failure to rescue, which basically translates in this data in another spin to suggest that it's not really surgeon volume, that it's actually the system, because the surgeon doesn't recognize the complication, but it's the system that does. And certainly the surgeon may repair the complication, but it is also the system that recognizes it early, gets the patient to the OR rapidly, and and helps to revert the mortality associated with the morbidity. And so I think again, it's the system is very important. We can't do complex cases outside the void of a good hospital.
Yeah, I think that's something we could really learn more from the cardiac surgeons. They don't do anything without their system in place, and probably we should be more like them, and only in that respect though. But at least we can learn something from them.
Great, nice job.
All right. Well, I think that that spurred a lot of discussion, and we'll move on to our next paper. Dr. Teeter, do you want to take it away?
Yep, let me share my screen. I take it everyone can see this and hear me?
Absolutely.
Thanks for this opportunity. Matt, our second year fellow, is going to fully take you through this paper in depth, baseline modern medical management in the BEST-CLI trial. Just as a brief overview, I want to talk a little more in detail about what optimal medical therapy means. Here we defined it as controlled blood pressure, smoking cessation, use of one lipid lowering medication, and use of an antiplatelet agent. And I think the real key takeaway from all of this is the overall adherence to this was extremely poor in this patient population that was studied. So if we look at our chronic limb-threatening patients in general, this is a subset of our PAD patients overall, who by comparison have an extremely high cardiovascular mortality and a very high amputation rate. These are some of the sickest patients that we take care of for that reason, and they deserve a lot of attention from a medical management perspective. Many societies have guidelines for how these patients should be treated. There are various different cardiology societal guidelines, but the SVS actually has its own guidelines specifically for how these patients should be medically optimized. I'm not going to go through these in too much detail, but I just want to hit on what the key points are from this. All patients with chronic limb-threatening ischemia should be treated with an antiplatelet agent. Those patients should use moderate or high intensity statin therapy to reduce all-cause and cardiovascular mortality. For patients with type 2 diabetes, consider control to achieve a hemoglobin A1C less than 7%. Controlling hypertension to target levels of a systolic blood pressure less than 140 millimeters of mercury and a diastolic blood pressure less than 90 millimeters of mercury. And offering smoking cessation to all patients who smoke or use tobacco products, as well as asking about smoking at each visit. And I think these are relatively straightforward and just give you an introduction to how these are defined. But then the next question is, do we measure up to our own guidelines? And this is another paper from JVS in 2023. They looked at VQI data between 2012 and 2016, specifically looking at optimal medical management, including antiplatelet therapy, ACE inhibitors, and statin use in this patient population, and found that it increased during that time frame. And there was an associated significant improvement in the overall survival and amputation-free survival. Dual antiplatelet therapy specifically was an independent predictor of improved limb salvage. And despite those improved outcomes and knowing this data, and there are numerous other studies that similarly highlight these medications and these medical managements either together or separately, 32% of patients were not on a statin, 30% of patients were not on aspirin, and of patients who smoked, more than 60% continued to smoke during the study. And I'm sure many of you probably read this editorial from a couple of years ago called "Who Will Own the Responsibility to Prescribe Statins?" And I have a direct quotation here that I think really highlights the degree to which this cannot be overstated. Given 57,000 annual deaths and 148,000 annual major amputations among patients with PAD in the United States, of whom only 6 to 18% are estimated to be taking statins of appropriate intensity, the scope of the opportunity is clear. And this is just a quick excerpt from another paper looking at rates and predictors of discharge on optimal medical therapy after lower extremity peripheral interventions. Female sex, older age, end-stage renal disease, chronic limb-threatening ischemia, and congestive heart failure were negative predictors of optimal medical therapy. So these are some of the sickest patients that are getting interventions, and yet they're also significantly less likely to be optimally medically managed. And with that, I'll hopefully let everyone reflect on opportunities we have in our own practice to improve our patients' outcomes, and I'll let Matt take it away and take us through the paper.
You just share my screen. Okay. So my name is Matt Pergamo. I'm the second-year fellow at NYU, and I just want to say thank you for the opportunity to present. And I'll be presenting the baseline modern medical management in the BEST-CLI trial. So a little bit of background. In 2010, there were greater than 200 million people living worldwide with peripheral arterial disease, and obviously that's over a decade old, so that number is likely higher. And that was a 23% increase from just 2000. Now, critical limb ischemia is what a small subset of those patients progress to, and actually the end stage of a overall systemic atherosclerotic process. It's defined by ischemic breast pain, non-healing ulcers or gangrene, in the presence of objective hemodynamic and arterial insufficiency. And patients with critical limb ischemia have a high risk of cardiovascular and limb-related complications. there are a number of societal guidelines that promote optimal medical therapy in PAD, but adherence is known to be poor and has been studied extensively. There's multiple studies that show that specifically patients with PAD are undertreated compared to patients with other atherosclerotic diseases. Therapy has been shown to improve outcomes in PAD. And I bring up this paper just as a good example of how they improve outcomes. This was for those patients who were adherent to guideline recommended therapies, they had decreased major adverse cardiac events as well as major adverse limb events. And that likely contributed to their third finding, which was overall decrease in mortality. Which brings us to the paper for today. The BEST-CLI trial was a multi-center prospective randomized trial. It was designed to compare the outcomes of patients with infrainguinal PAD who underwent endovascular treatment versus open bypass surgery. After enrolling patients, they were divided into two cohorts. One cohort that had adequate greater saphenous vein, and that was 1,434 patients, and those that didn't underwent bypass with an alternative conduit, 396 patients. Those the ultimate takeaway from that study was that patients with adequate greater saphenous vein likely benefited from a bypass prior to any endovascular intervention. And for those with an alternative conduit, the results were equivocal. But the authors of that study wanted to examine the medical management of these patients, as it's known that adherence to optimal medical therapy has been poor in our patient population. In terms of their methods, their patients were over 18. They defined CLI as patients with dry gangrene, non-healing ulcers, and ischemic rest pain. Their exclusion criteria are those who were considered excess risk for open revascularization, defined by the AHA or also by clinical judgment. And the primary endpoint was major adverse limb event. Secondary endpoints were major adverse cardiovascular events and health-related quality of life. For this study, they because it was examining just the overall use of optimal medical therapy, they pulled the cohorts of 1 and 2 just to come up with a large patient population. And the use of optimal medical therapy was recorded at trial entry. This was following consent, but prior to their randomization and revascularization. That optimal medical therapy was decided by a committee across multiple disciplines, and they came up with an ideal guideline-based protocol as well as a score for how those institutions would be followed and what follow-up data to collect. 5 areas that were assessed were control of hypertension, smoking cessation, lipid-lowering therapy, and antiplatelet therapy. For diabetes control, the data was entered voluntarily, and so they had a lower number of patients that with available hemoglobin A1C levels. Here are their results. So a total of 1,830 patients were enrolled. And this table, that was the second table, was just strictly looking at the demographics of the cohort. 87% of them had hypertension, 74% had hyperlipidemia, 36% were still currently smoking. Which is, over a third of their patients were still smoking, and 69% of the patients that were examined had diabetes. And this is the first table in the article that was kind of the main point, which was the optimal medical therapy use at baseline. And so you can see that the criteria is there to the left, and that the pooled number of patients was over to the right. And you can see that for patients who had controlled blood pressure, there was approximately 63.5% who were met the criteria for optimal medical therapy. 64% were not currently smoking, 72% were on one lipid-lowering medication, and 73% were on greater than one antiplatelet agent. Again, the data for diabetes was about half because the A1C levels were voluntarily entered. And then they took the optimal medical therapy criteria and their use and divided it by region. For lipid-lowering medication, antiplatelets, and diabetes, the numbers were relatively the same across the board. What I thought was interesting is that in the not currently smoking category, you can see that in areas that there's known greater prevalence of smoking as in the South and Midwest, that the numbers for meeting that guideline were lower than in the other areas of the country. And for blood pressure control, interestingly, here in the Northeast, we do seemingly a worse job of controlling blood pressure, meeting only 57% compared to the West Coast, for example, who had 70%. They then pooled the data for each patient in terms of how many criteria they met, and they only counted 4 because of the missing data for the diabetes. And you can see that there was, as Dr. Teeter mentioned, poor adherence, and only approximately 25% of patients met all 4 criteria. So only a quarter of patients were on optimal medical therapy at the time of enrollment. They then did a multivariable analysis to look at what determinants of optimal medical therapy there could be. And what was interesting about this was, as expected, patients who had coronary artery disease as well as prior stroke demonstrated higher use of optimal medical therapy at the time of enrollment. Black race was associated with a decreased rate of optimal medical therapy, which the authors did not delve into, but indicated that was one of the limitations of their study. So the key takeaway from the paper is that there's a significant portion of patients who were enrolled in the BEST-CLI trial that did not meet optimal medical therapy at the time of enrollment. I think one of the main points in discussion that I thought was significant was the use of statins. So this is the paper that they cited within the discussion that demonstrated that there was a 25% lower likelihood of amputation and a significantly lower chance of a fatal event. And despite that, a third of patients were not receiving a statin that were enrolled in the BEST-CLI trial. And then that's a discussion they go throughout the other findings, such as for blood pressure control, approximately 30% of patients were not on adequate antihypertensives at the time of surgery. And they used a less stringent guideline compared to other societies that have come out with even more stringent guidelines for blood pressure control, such as a less than 130 or 140 for the elderly. Diabetes, which is associated with worse outcomes for patients with PAD, there was only limited data gathered, but even of that, only approximately 1/3 of those patients were not achieving adequate glycemic control with an A1C goal of less than 7%. And there were 36% of patients were currently smoking at the time of enrollment, and that represented likely missed opportunities for smoking cessation counseling. For one of the major points of the discussion that I think is very relevant is that patients with CLI receive suboptimal care compared to other atherosclerotic syndromes, particularly coronary artery disease. And there's actually a paper out of NYU that was published a few years ago that looked at the annual number of ambulatory visits in the country and showed that when patients underwent a visit for just peripheral arterial disease alone, they were less likely to be prescribed antiplatelet therapy, statins, ACE inhibitors, or counseled on smoking than when they presented with both PAD and coronary artery disease at the same time. In terms of limitations of the study, it currently is only measured rates of optimal medical therapy preoperatively and did not delve into how that changed after randomization, as well as post-intervention, how that may have affected outcomes in their cohorts. And I think they indicated that those studies might be coming. Medical therapy has continued to evolve as the BEST-CLI trial was ongoing, such as the evolution of PCSK9 inhibitors and different diabetes medications. There was limited diabetes data because it was entered voluntarily, and that is one of the biggest risk factors for progression of PAD, as well as poor outcomes. And then they did not go into the socioeconomic factors at the time, though indicated that, again, that they, I think, plan on examining that further. And I think that's it, actually. Thank you.
Great. Thanks for a thorough introduction to the article, and thanks, Dr. Teeter, for introducing us. Dr. Menard and Weinberg are with us tonight, so hopefully we'll be able to participate in the discussion. It looks like Dr. Sheehan has sort of kicked us off with the question of, is it possible to tie outcomes to medical therapy within the BEST trial population? Is this data coming? Matt, do you mind not sharing your screen just so we can see people that are...
Oh,
Sure. Am I, oh, okay. I meant me.
But she
Yeah,
does
no,
want you to answer the question.
Oh, so
yeah,
yeah, unless
no,
she has a question, sorry, other Matt.
yeah, lots of Matt. So thanks, Catherine and Matt. That was fantastic. Kind of tee up and background, obviously a big topic. Yes, that's absolutely the goal. We're actually hard at it. Looking at, a couple things. What was the impact of participation in the trial? With all this attention to medical therapy, it was a very difficult trial to enroll into, to follow patients. This was one component. It wasn't the central component, but we did try to stress that it was an important component, to the point of forming a committee of experts trying to define what it is. But we are looking at the data, both to tie outcomes to use of different components of the medical therapy, but also, more detail about what are the predictors of success or failure in, what's clearly a very hard problem for us as vascular surgeons, and everyone else in the vascular community to do better.
I think Dr. Humphreys has a great question in the chat, and this is really what it all comes down to, right? Is how do we do better? And I think this could be probably for both the authors of the paper and the discussants. I mean, how do we make a difference here? It looks like we've been talking about this for over 10 years.
Yeah, I've
Dr.
got some thoughts,
Pergamo?
but why don't you jump in?
No, hey Matt, hey everybody. I super appreciate you all letting me join, and the discussion has been super interesting up till now. The presentations were great. And if low volume operators can come to the same, results as high volume operators, I'm thinking of operating on an aorta tomorrow. Let's see how that goes for a non-interventional vascular medicine doctor, and I'll report back to you all. Just to answer the question, how to move the needle is hard. I happen to be the president of the Society for Vascular Medicine, so my answer is obvious, right? Vascular medicine physicians, we need more non-interventional clinical vascular medicine physicians and other such people. In many centers, my colleagues work with you all, with vascular surgeons in the same practices, helping manage patients medically. And we actually have a special issue coming out from the Vascular Medicine Journal, showing that when the vascular medicine physician is involved in care, the medical side of care improves. And so, everybody here is, I've been blessed to be part of this community and kind of have so many friends on both sides. And I feel like that's a great solution. The second thing is, implementation of guidelines. There's a lot of data coming out, showing a huge lag between when guidelines come out and when people actually adopt the guidelines. And having content experts and sort of people who kind of, hold the torch within institutions and kind of run with it within institutions, quality improvement, et cetera, that has been shown to have a great effect positively on patients. But I'm actually going to also say a third controversial thing that has to do with the first question asked about outcomes. And I'll say that obviously, we're going to work on that and you'll see the results at some point. I'll just throw out there that all the data that you saw in all the introductionary slides pertain almost exclusively to patients with quote unquote peripheral artery disease. The data on the sicker cohort of patients with critical limb ischemia is much more limited. And whenever I'm invited to a conference to talk about how do we improve outcomes in patients with critical limb ischemia, I find myself quoting the data from PAD because we lack the data on CLTI. And so this is where this study is really going to kind of teach us all about how to improve the outcomes of our patients.
Dr. Pergamo, did you want to weigh in?
Yeah, I think that it's a very difficult patient population, and it's hard to measure adherence to medical therapy. But I think one of the difficulty with surgeons, and the reason that it would be important to have a vascular medicine doctor there, is that we see patients post-operatively maybe once or twice, and then we don't see them again for a while they go back to their primary care doctors and other people that might be easy to be what we say to manage the medications. But I think we should take it upon ourselves a little bit to take a look at their medications at their visits as well. We might be able to make a difference that way. But
Yeah, Matt, I'd like to just jump into that. So, so I'm blessed at the Brigham. Someone on the chat said they're blessed at Jeff. Have excellent vascular medicine folks. I think we get a little bit lazy or complacent, and we kind of lose, because it's easy for us to say, oh, you guys are going to take care of it. So I think that's a little bit of a sand trap. And I wanted to jump in. I just have this sense, I don't know if it's right or wrong, but that you guys do better in the coronary world. In particular, if someone comes in with an acute coronary syndrome event, that's a moment, and you don't leave the hospital until you're on the right meds, or unless you're on the right meds, and you don't leave the hospital until you have follow-up set. And that's tied to a couple of things, I believe, reimbursement, and also kind of a metric that CMS is paying attention to, which I think is readmission, which is obviously completely flawed and not the perfect metric. But the point is, it's far more sophisticated. No one's watching us. No one's tallying anything we do. And so we either kind of do some things or we don't. But is that a misconception, or is that a room for improvement maybe in our world?
No, I actually want to give it a positive spin if that's okay. I feel like it is much, everything is difficult and everything requires attention. So what I'm saying is a little sort of flat, just to make a point. It is easier sometimes to treat a patient with coronary artery disease and to offer them medical therapy, because coronary artery disease is ubiquitous and it is very scary for patients. And like you said, it is a specific moment, and it happens to people of all walks of life, as opposed to CLTI, where we have to overlay this with oftentimes it is sort of an insidious condition that kind of creeps up on people until you get to that moment. And that's very different. Secondly, it oftentimes happens to people with, socioeconomical disadvantages, racial disadvantages, etc. And oftentimes it happens sort of in the periphery and not in the central sort of, mainstream of life, which makes, our job as a community much, much harder. And thirdly, the resources offered for sort of the management of like you said, there are systems in place for the management of sort of the coronary disease and other such conditions is different by magnitude than what we are kind of dealing with when we are treating our patients. And so all these obviously add up and come together to what you're all seeing in the results that were shown so nicely.
I think that leads us to the sort of next comment from Dr. Abai in the chat is, it's one thing also to prescribe these things, but how do we ensure patient compliance, and how do we measure that? Anyone? Dr. Weinberg, you have a comment?
No, I'm happy to jump in. I just don't want to, like anybody else, I love the sound of my own voice, but this is again a matter of just having the bandwidth to do so, and just I really I forget who presented this, perhaps Dr. Tedder, that slide about who owns the statin administration, right? And so and we all know, I can tell you, a patient comes in that they come with a specific question, that has nothing to do with the statin, and oftentimes we will focus on that question, and we will not address sort of the patient holistically. My point being, trying to answer your question, that we need somebody with the bandwidth to be able to, whose job in life, is to sit down and just go over those exact things, ask about them, document them, and confirm, within a short time frame that these things are actually being implemented. And I think that's the only way that these things will work.
Want to highlight something that sort of stuck out at me when I was looking through this paper was the racial disparities in the medication prescriptions. And I suspect that these are largely surrogates, right, for socioeconomic disparities, which you alluded to a little bit. But that's a harder nut to crack, right? If you're not getting patients to the doctor, how are they treated appropriately? How can we do better at that?
Yeah, I want to shout out to my partner and friend, Dr. Gaurav Parmar, who publishes on social determinants of health. And we have actually shown out of the enhanced database, which is going to surprise you because it's an old database from the year 1999 through 2000 and a little, but we have 20 years of follow-up, right? Because it's so old. And the social determinants of health are much more than race only, just like you said, Dr. Hicks. And so it is a much more complicated issue than to simply sort of put in our minds, oh, if we see a patient of a certain race, we need to do better. It is much more complicated, and in order to improve the care for these patients, we need systems-wide approaches that go far beyond sort of our office.
Really, really quick last question before Dr. Humphrey shuts me down. Dr. Menard, do you have post-intervention medication data? Are we going to be able to see what happens after people leave the hospital? Are we taking advantage of that opportunity?
Yes, that's coming. That's what I alluded to earlier.
Great.
Yes, stay tuned.
All right, well, we've had such great discussion, and I want to thank everybody. Thank you to our moderators, Dr. Eagleton and Dr. Hicks, who were from the editorial board here with us, and thank you to the authors. It's really great to have the authors here because there are questions that come up about the methodology, that come up about, what is something that's just kind of glossed over in the paper sometime, and we like to get this in-depth kind of discussion. So thank you, everyone. And then, of course, to our sponsors, LSU and NYU, we're very grateful to have everybody here tonight. And then we'll see you all in October 11th at 6 p.m. Central Time. Check social media, check the SVS website, and we'll see you all then. Good night.
Thank you all. Have a good night. Thank you.
Thank you all.